Findings in a first time or occasional passive agent. Buttock, not a fresh or healed lesion, dried secretions, ecchymosis, rashes, STD lesions, handprint or fingerprint. Perianal skin, examine for presence of inflammation. Record findings of dried secretion, bruising, tear, laceration, fissures, tear or laceration that are located on the external surface, internal to sphincter, or extend across the pectineal line, which is the junction between the anal mucosa and the epithelium, anal orifice. Irritable mucosal rim prolapsed. Mucosal rim prolapsed, tender to touch. See how it admit the index finger. Only one finger is admitted with a discomfort. A full act has not takes place. Two fingers are admitted with a slight discomfort. Full act might have taken place. Anal laxity. Note dilation and loss of elasticity, loss of normal and anal tone. A visual examination is almost always sufficient to assess anal tone. Avoid a digital rectal examination in children unless there is suspicion of internal trauma. On a visual examination, note the presence of anal spasm. Estimate or measure the diameter of any anal dilation. Lateral buttock traction test. The buttocks are spread by thumbs of both hands, causing enough lateral traction to separate the buttocks and visualize the anus. Note the length of time to reach maximum dilation, whether the dilation was constant or intermittent. In case of a positive finding, dilation generally occurs within 30 seconds. Anus dilate to more than 15 millimeter, more than 50 millimeter in diameter, and without a stool present. Index finger without discharge, so velocity, no loss of normal tone. And without a stool is a significant observation. In a habitual catamite, the complete relaxation of both internal and external sphincter occur with a dilation of 40 to 50 mm, 4 to 5 cm diameter. Rectum can be seen through it. Blood stain around anus, on perineum and on clothes. If occult blood is suspected, perform a Guaic or any other person T test for blood. Fecal matter around the anus if there has been incontinence. Hematoma frequently seen as a localized swelling or a diffuse swelling around the anal margin. There may be obliteration of normal anal skin fold. Abrasion. Abrasions, that is scratch abrasions varying in number, extend from anal margin into the anus. If specks of blood are abhorrent, it suggests a recent act. Anal canal, look for any foreign body. Laceration of anal canal seen if violence has been used, especially if the victim is young, rare in adult, but seen by pulling the skin outward, cause overstretching of the skin. Appearance as large as seen as large fissures, triangular or wedge-shaped, generally simple and seen at the posterior part of the anus. Base is directed externally to anal ring, apex upward and inward. Might bone only external skin may extend within the anal canal to mucocutaneous tension. Laceration of the sphincter, NA, seen if violence has been used, especially if the victim is young, rare in adult, anal prolapse. Findings in a habitual agent. Anal hair shaved, anal orifice dilated, inelastic, lax, overstretched. Elastic anus, one capable of dilatation, does not include habitual agent. Anal margin and skin around the anus is smooth and thickened, extending into the anal canal up to the mucocutaneous junction, sometimes into the upper anal canal. Epithelialization of the anal mucosa. There may be anal fissures and scars. Anal fissures and scars may reveal hemorrhoid. Anal muscle tone is lost. Anal reflex contraction of the anal sphincter on irritation of the anal skin is delayed. Funnel-shaped anus is rare and usually an anatomical variation. However, slight depression of buttocks towards anus may be seen due to absorption of fat. Lateral buttock traction test. Anal mucosa, absence of fine spindles. Anal disease, anal condyloma of anal disease, condylar accumulation, signs of anal neoplasia may present. Examination of the active agent. Examination is conducted on the same general line as that of active serotype. Preliminaries, consent must be taken. If arrested, may be examined without consent under section 53 CRPC. History. Active agent is usually the accuser. His version of details of the event must be recorded. Examination of cloth. Dissolved and tonic passive agents resisted may show seminal and fecal stains. Well examination. Injuries consistent with resistance, struggle faced, example abrasion, bruise, teeth mark, etc. Blood and seminal stain on the body. Local examination. Penis may be elongated, constricted at some distance from glands. Urethra may be twisted, redness and swelling due to friction and irritation. Traces of fecal matter and lubricant. Peculiar smell of fecal feces and anal glands. Abrasion on trapezius glands. Penis. Tearing of frenulum. Coronal sulcus showing fecal soiling, blood falling hair. Urethra swab. Smears should be taken from the urethral meatus after applying pressure on the upper surface of the penis along the urethra. May show fecal material. Culture may show organism gonocoque similar to those found on the anal virgin swabs from passive agent. Corroborate nutrition. Specimens to be collected. Both active and passive agents may have interchanged roles if there was a consensual act. Food. Blood for venereal disease, testing for HIV, urine, nail scrapings, hair, head hair, pubic hair, loose hair and fibers anywhere on the body. Swabs from any soiled area of skin, from anal, perianal, local rectal area from suspect passive agent, from shaft of penis, coronal sulcus and glands from suspect active agent. Thank you.